I'm not ready to throw in the towel.
For you? Okay. Her ICP is unresponsive.
You're planning to do the surgery on Gina's behalf.
Oh, now that is good television. Whoever wrote this, well done. They just told us that they have a medical power of attorney to make decisions on Gina's behalf. Very excited to be reacting to Chicago Med Season 1, Episode 1, recommended by our only Omega channel member, Laszlo Kozma. I'm going to be giving my insights as a doctor working in London.
Can you sit for a second? Alright. It doesn't look too bad, alright?
Oof, what an opener! What he's doing there is basically wartime triage. 20 patients, 1 doctor. Who do you treat? He needs to identify the sickest patient and help them first, but only if they're savable. If the injury looks terminal, then actually the doctor's efforts are better served elsewhere. That's the reality of disaster medicine. One of my profs at uni was a surgeon in the battlefield at the start of the Central African Republic War, and he managed to save a soldier that was 12 years old there. Crazy. It's also interesting that in this Chicago Med episode, a new A&E center has just opened up. Great timing.
CFD Plan 2 mass cash. Multiple trauma patients minutes away. Let's go.
45-year-old male, left leg amputation.
Treatment 2.
Trey Motorman, GCS3, BP of 90 by PAL.
Oh my lord. Seems like the patients on the bus got off light. The train, on the other hand, wasn't so fortunate. The memory that sticks out for me of an emergency that happened outside of hospital was a 48-year-old male that had collapsed just by the clinic opposite the hospital, and a passerby called us as the crash team who went to see the patient. When we arrived, he barely had a pulse. We had to fluid resuscitate him, then bring in a defibrillator and shock him as he slipped into VF arrest. We managed to get him back and he went straight to the intensive care unit. Turns out he was one of our professors that just finished a clinic, spent his whole life helping others. He definitely deserved some back.
28-year-old male, crush injuries, severed artery, massive blood loss.
Grab 4 units of O-neg and start with the round of epi.
Already hit him with the epi times 2.
I got it from here, man.
Nope, he's mine.
Get off the gurney, doc.
Oh, seems like there's a turf war going on, and the patient's like, don't mind me. I've just lost 70% of my circulating volume. I'll just wait here while you discover who has the longest cucumber. Also, we actually have a machine now that can do chest compressions for the paramedics to stop them from doing this exact situation. Compressions on a moving trolley, which is quite difficult. It's called the Lucas machine and it's pretty incredible, although it does look a little bit more dramatic in real life sometimes. In all fairness as well, if someone had a crush injury and severed artery, you'd want to clamp and shut that as quickly as possible while you reinfuse the blood to get the pulse back. Sterile, not sterile. In a situation like this, it doesn't matter, courtesy of Alexander Fleming. Clamp first, antibiotics later. Alexander Fleming discovered penicillin, by the way, actually in my local hospital. It makes me feel proud, even though I wasn't even a sperm when that happened.
I'm senior resident in this ER.
Yeah, well, I'm your new trauma fellow.
Female, early 20s, head trauma, GCS3, unresponsive in the field.
We gotta change that King Airway to a formerly
The
T2.
patients are coming in thick and fast now, kind of like that trauma fellow winning the cucumber fight. The grades of doctors can be so confusing even to other healthcare professionals. Resident this, attending that. We should just have stripes like the army, or different length cucumber emojis on the uniform. Ideas like that are why I'm making YouTube videos, not running a hospital. Basically in the US it goes intern, resident, attending. After 3 years of residency you can apply for a fellowship if you want to enter academic medicine or do a higher specialty training. In the UK it's foundation training, core training, registrar, which is me, and a consultant.
I can't find the vein.
Again, 200. Clear.
I have a pulse.
And he's back. Get his blood gas and get him to the OR.
Oh, interesting. We still don't even know our protagonist's name yet, but he seems to be running the show. Usually in a trauma situation like this, it's important that the person calling the shots doesn't get pulled into doing many of the actual jobs needed, like chest compressions or taking blood samples, although it does look quite heroic. The reason why is they need to keep track of time and drugs given and delegate each of the actual jobs so that they can maintain an overview of situational awareness. If you're focused on just one task, then it's easy to miss some of the other things that are going on around you, like the ECG trace monitor or how long it's been since the last adrenaline was given. Of course, though, if they're the only competent person to do a specific task, then that's fair enough, which seems to be what happened in this case. I felt bad for the med student though, not being able to get the vein, had the syringe snatched off her. To be fair, during a life or death situation, that can be necessary. I remember when I got my first femoral stab during a cardiac arrest, felt like a huge achievement, especially because we got a good outcome resuscitating the patient.
Why am I putting in this bowl? Where's my good-for-nothing resident?
Put in her 12 hours. Had to knock off.
I'm so tired. I can't work.
You're the baby's mother?
Gina's our surrogate.
I'm done.
This is getting spicy. So not only is the unconscious patient pregnant, but she's the surrogate for the biological mom who's in the room. Damn, I hope the mother doesn't deteriorate, because they may have to do an emergency C-section to get the baby out. That would be troublesome for the surrogate. Really tough decisions coming. Speaking of tough, have you seen this old school neurosurgeon? Having time limits on working hours is definitely a good idea. Physicians experiencing burnout are over twice as likely to make a serious medical error. I don't know about you, but if I had a doctor who's about to stick a drill in my head, I would have wanted them to have 8 hours of solid sleep, a strong, nutritious breakfast, listen to whale noises all the way to work. Maybe you've just had a foot massage. So here's a question for you smart people. What percentage of a mother's blood flow goes to the baby at term? Drop your answers down below.
But if the worst did happen, it might be possible to keep her on life support long enough for the fetus to become viable.
A human incubator.
We're not there yet.
Oh, this is horrible to think of, but there have actually been cases in real life. It's called maternal somatic support after brain death. There was a case in the Czech Republic where a mother was 16 weeks into a pregnancy and had a stroke that caused full brain death. She was kept on life support until the 34th week of pregnancy and delivered her healthy baby on the 25th of August 2019 via C-section. Crazy.
You close that like a plastic surgeon. Where'd you pick that up?
Riyadh. Saudis paid me well not to leave unsightly scars.
Who's young Rambo over there?
Young Rambo, being able to suture without leaving a bad scar is a very valuable skill. There's a way to do it fast with staples, but not very aesthetic, as the staple holes can scar and be visible long term. There's a way to get the job done sloppy with an interrupted stitch, and you can do it slightly better as well. This example is of a more sloppy one. There's also a way to do it spicy, like my Arab brothers want it done. And most surgeons do it this way, to be fair. Now, if you're enjoying the content and you want to help make the channel as beautiful as young Rambo over here, then check out our channel membership. Not only does it support me, but it also gives you access to some exclusive perks, like being able to suggest series and episodes for me to react to, and getting early access to new videos. For limited time only, our first 30 members will also get access to a raffle for a one-on-one tutoring session with me for a topic of your choice. We currently have 10 members, so make sure to secure your next spot. And also, the earlier that you join, the earlier that I can react to your suggestions. Now back to our video.
You're pancytopenic, which means that your cell counts are low. You've got a blood pH of 7.14, which means you're getting fatigued.
I've been intubated 8 times.
8 times! Oh. This poor guy has cystic fibrosis and seems to be somehow related to the chief of psychiatry in the hospital. Came in totally unrelated to the accidents with what seems like a chest infection. There is some inaccuracy here though, as a blood pH of 7.14 is so acidotic that it's likely that the patient would either be unconscious or severely confused, which we call moribund. With that, the usual lower limit is 7.35. Now, blood pH is controlled by a gentle balance of acid and base in the blood. The body usually wants to keep it within tight limits, where it works best, and this equation controls everything. So H2O plus CO2 equals H2CO3, which is a bicarbonate, and then that can push to bicarbonate ions and hydrogen ions. Now, the clinically very important parts of this equation are the CO2 on the left and the bicarbonate and acid on the right. Now, this patient could not be breathing off CO2 very well because of the cystic fibrosis, or he could be septic due to an infection, which could cause acidosis through tissue hypoxia and production of lactic acid. So how do we know which? Because the treatments would vary slightly. We look at the bicarbonate and the carbon dioxide in something called an arterial blood gas. If the carbon dioxide is high, then it's a respiratory acidosis. If the bicarbonate is low, then it's a metabolic acidosis. And even spicier, if both of those are present, then it's a mixed respiratory and metabolic acidosis.
Give her a dose of mannitol and increase her dopamine trip to 12. But the swelling of her brain is getting worse.
We're going to try to control it with medication. And what if the medication doesn't work?
Then she'll require surgery.
Okay, so even though Gina has regained some movement, it looks like the swelling in her brain due to the trauma is increasing her intracranial pressure. We worry about that a lot since the brain is kept in a confined space with a large hole at the bottom named the foramen magnum. I don't know why they named a condom brand after it since it doesn't offer much protection. If the pressure gets very high in the brain, then parts of it start to drop down through the foramen magnum in something called brain herniation. That's less sunshine and rainbows and more a one-way ticket to meet Rebecca Black's music career in the afterlife. We obviously want to stop that, and mannitol is a very heavy sugar that draws in water from the brain into the bloodstream to help reduce the swelling. If that doesn't work, then a decompressive craniectomy basically opens up the skull so the brain can come out of there instead of herniating. Disaster averted.
You know what's gonna happen. Jamie will lose consciousness. And as his doctor, I'm gonna put him on a ventilator, but by then, it may be too late.
Wow, wait a minute, young Rambo. I'm not a fan of scenes like this for a few reasons. So number one, the patient has stated that he doesn't want intubation and resuscitation quite clearly. In situations like this, there is a form called a do not resuscitate form, or DNAR, which is placed clearly next to his bed. This shows all healthcare staff that if he goes into respiratory arrest, then he should be allowed to die naturally. The second thing is that a doctor can act in a patient's best interest in an emergency situation where there's no advanced decision made. The patient's clearly conscious enough to make that decision before losing consciousness. If the doctor then intubates him, then he's violating the ethical principle of autonomy, which is to respect the patient's wishes, although there are some complicating factors since other ethical principles like beneficence would say do the best for the patient, and what is best for the patient is a really difficult thing to figure out in this scenario. Then the third thing is that Dr. Rose said the reason why this patient should live is that new treatments for cystic fibrosis are coming. This was filmed 8 years ago and there's still not any convincing new treatments. Dr. Rhodes also said that he would be able to access a lung transplant. Even if so, the outcomes for cystic fibrosis patients with a lung transplant based on Liu and colleagues' 2001 paper are highly variable, and some patients actually do worse with a transplant rather than not. So it's definitely not a magic bullet cure, even if they manage to get hold of one. This patient obviously has suffered a lot with a poor quality of life, and it doesn't necessarily want to live. As a doctor, it's just as important to know when to step back as when to treat.
I'm not ready to throw in the towel.
For you? Okay. Her ICP is unresponsive.
You're planning to do the surgery?
I don't see how we can sign off on a procedure knowing it will endanger our child.
Oh, now that is good television. Whoever wrote this, well done. They just told us that they have a medical power of attorney to make decisions on Gina's behalf. They don't want her to have the surgery, but her raised intracranial pressure is stopping blood from getting into the brain. Now, in real life, this wouldn't happen as a surrogacy agreement doesn't come with a medical power of attorney. In the US, there are no federal laws that actually protect surrogate parents, so it depends on the state. Chicago is one of the most surrogate-friendly states, so the biological parents can be named on the birth certificate when the child is born. The UK can't actually enforce surrogate agreements even if they're in place, and so at birth the mother will be the one who carries the baby, and you would need an adoption certificate or another agreement to transfer parental ownership. Anyways, this situation is very interesting. Gina's cerebral perfusion pressure should be between 60 and 80 millimeters of mercury. Hers is 40. It's actually calculated by the mean arterial pressure minus the intracranial pressure. So as the intracranial pressure rises, the cerebral perfusion pressure drops. That's a lot of technical mumbo jumbo, but what it means is that if they don't act soon, then she could be brain dead and will end up with another case like the Czech Republic one. What would you do if you were the parents with the power of attorney in this situation? Let them do the operation and try and save Gina's life, or allow her to become brain dead and used as a human incubator? I know what I would do. Drop your answers down below.
And you think we're monsters?
I think that you and your husband are faced with a very difficult decision.
There's no more embryos.
Oof, look, Sharon Goodwin, Chief of Services, has come down to discuss this. The other doctors were strong-arming, guilt-tripping, asking questions like, how can you just let her die? That indicates a lack of understanding and toughens people up, putting them on the defensive. As Chris Voss, hostage negotiator and author of international best-selling book, Never Split the Difference, says, lead with empathy. One of the strongest human impulses is reciprocity. Sharon immediately said, I think that you and your husband are faced with a very difficult decision. Automatically showing her that she's attentive, listening, and causing the surrogate to open up and reveal that there are no more eggs available. That this is their last chance to have a child. The defenses are now down and a real conversation can happen. This is how you diffuse a situation and are the fundamental principles of negotiation. Now, if you're interested in hearing Chris Voss's book, you can get a free download of the audiobook through Audible if you use the link down below. Following the link also helps to support the channel as it's an affiliate link.
What are we supposed to do?
You have to ask yourself what you can live with. Gina handed over her life to you in that contract. She trusted you to make the right decision. I'd want to live up to that trust.
Interesting. So do you see how the surrogate mother's guard was down? She began asking for advice as she began to see that she's not being judged or attacked. She was being understood. Sharon then framed her answer to what are we supposed to do from the perspective of the surrogate mom, explaining the direct disadvantages to her in making that decision, like what would you be able to live with in the future? After that, there were a few ways she could have gone with it though. I'm not a huge fan of her saying that Gina handed over her life to her in the contract and she trusted you to make the right decision, as that can come across as judgmental, implying that you are making the wrong decision, like an authoritative kind of parent-child kind of situation. What I would have said instead is, you and your husband are trustworthy people. Gina bet her life on that, and you know it too. If I were you, I'd stay true to myself and let Gina have the surgery. Then it becomes a moral issue about the surrogate mom being true to her character identities, the way that she sees herself, rather than an externally imposed idea of right and wrong. It's subtle, but there's a big difference there.
Removing cranial flap now. If we wait any longer, she would have herniated.
Fetal heart rate is dropping. 100. Tracings look like crap. That strip doesn't correct in 30 seconds. We're crash sectioning her.
Give me suction.
This is tense. Good thing they got her in when they did, but if the baby starts to show signs of distress during the operation, then they would be doing a C-section now. A little frustrating. We're not sure how late into the pregnancy she is, as it does make a huge difference as to whether the baby survives or not. Believe it or not, at 24 weeks, which is the threshold for abortion in the UK, 60% of babies could survive. At 22 weeks or less, less than 10% actually are able to survive. That's because in those 2 weeks, there's a huge difference to lung maturity and other vital organs. Let's hope it doesn't come to that though.
The crash victim I'd been treating has died. He's a match for Jamie.
Let's get him some lungs.
Central line. I can't tell you how many times I missed it before I finally got it.
Dr. Rhodes showing some empathy for the med student here. He seems to get on well with females. Males, he's okay with, as long as they're not giving him a challenge. Seems like he needs to assert his dominance. Hope he doesn't start urinating on the nurses' station soon, although maybe they're into that. Also, that is very fortunate that James had some lungs that are a match. The average wait time is 18 months for a lung transplant. I like how the show is demonstrating that there are two sides to every coin. Someone's death could give life to another. More people should really sign up to become organ donors. This episode is actually pretty good. I would say 7 out of 10 for entertainment, maybe 5 or 6 out of 10 for accuracy, and diagnostics 4 out of 10, although it doesn't seem that the episode is tailored for diagnostics.
They got the first lung in.
Halfway there? And this kid did more things than most kids his age ever do. He went for the swim team in high school. Kid was CF. Taught me how to cope.
Going back to the hospital. Can I come?
Oh, Dr. Rose has some serious commitment there, attending the hospital again, even after his shift is finished. Impressive he goes back out of hours, but that is actually a life of a surgeon. You're either in it or you're not. That's what part of the reason why I thought family medicine would be a better life for me. You know, if I had chose cardiac surgery, what do I do if it's my daughter's birthday and one of the patients I've operated on is bleeding into their chest? I have to leave and go. When I was on cardiac surgery, a renowned surgeon from a neighboring center had actually passed away. At the funeral, someone actually asked his wife how she was coping without him, and she said he was a brilliant surgeon, but nothing much has changed. We never saw him before, and we still are not seeing him now. That really hit home. Still though, he contributed massively to the field, and I'm sure will be remembered for many generations. With stories like this, now you'll have to watch another. Stay curious.